Let us now go to the management of asthma. The goals of asthma management include achieve good symptom control and minimize future risk of asthma-related mortality, exacerbations, persistent airflow limitation, and side effects of treatment. Again, I'm showing you now the asthma management cycle wherein it is very important to review, assess, and adjust with every consultation that our patients with asthma would have with us. So what are the medications and strategies for symptom control and risk reduction? The key points in the management of asthma, particularly in GINA, is that GINA does not recommend treatment of asthma in adults with short-acting beta agonists alone. So we have to make use of ICS-containing treatment to reduce risk of serious exacerbations and to control symptoms of asthma. We are also required, or it is also recommended rather, that we use treatment tracks that are given by GINA. So what are the categories of asthma medications? These medications are either controller or reliever. Controller medications are usually ICS-containing medications or inhalers that used to reduce airway inflammation, control symptoms, and reduce risks such as exacerbations and related decline in lung function. So there are actually two tracks in the GINA 2023, and track 1 is usually the controller is delivered through an anti-inflammatory reliever or a low-dose ICS formoterol. Reliever medications, on the other hand, these are the medications or inhaler that are used as needed for the relief of breakthrough symptoms, including during worsening asthma or exacerbations. This would include anti-inflammatory relievers, ICS formoterol, and ICS LABA and SABA alone. Asthma treatment is not set and forget, and it's not just about medications. It's actually a repeated cycle of assess, adjust, and review. Under assessment, we have to determine the symptom control or the asthma control of the patient, as well as to determine the modifiable risk factors that may have an impact on the symptom control of the patients in between consults. We also have to assess and address the different comorbidities that the patient has or the patient has been recently diagnosed with. We also have to assess inhaler technique and adherence. We have to review because sometimes the technique is no longer as perfect or as good as when you first saw the patient and taught the patient on how to use the inhaler. And under adjusts, we have to address the symptom control of the patient as well as the possible modifiable risk factors that may have a control or have an impact rather for the symptom control. You also have to adjust the different non-pharmacological strategies as well as re-educating the patients on the importance of compliance of medications with inhaled corticosteroids and not just making use of a plain short-acting beta agonist like your salbutamol. Then we have review. We also have to review the different symptoms of the patients and episodes of exacerbations in between consultations, as well as possible side effects of the inhalers, and somehow address it or perhaps even consider changing if the patient requires or asks for it, or if the patient is really uncomfortable with the said side effects. Then we also have to also review patient as well as the caregiver satisfaction as with regards to the present treatment. This is the GINA 2024 stepwise approach in the management of asthma. there are two tracks, track 1 and track 2. Track 1 is what we call as the preferred approach, while track 2 is the alternative approach. Track 1 makes use of a controller and reliever treatment in one inhaler, while track 2 is making use of a controller and a reliever separately, meaning the two medications, the controller makes use of one inhaler and the reliever makes use of another inhaler. So in track 1, we make use of an inhaled corticosteroid combined with formoterol as both a control and reliever because it has been found to reduce the risk of exacerbations compared to using a SABA reliever alone. And it's actually a simpler regimen because we only make use of one inhaler. So these steps 1, 2, 3, 4, and 5, we actually take into consideration the control, the symptoms of the patient in between consults or for the past few weeks, for a month, and then we tailor the patient onto which step he or she or our patient should make use of. Okay. So take note, reliever is the one inhaler is being used as a controller and reliever for track 1. In track 2, which is the alternative pathway or approach, so we make use of an inhaled corticosteroid and a long-acting beta agonists with a short-acting beta agonist as a reliever. We can actually also make use of an ICS-SABA combination if these are available. Okay. So for track 1, so as you go higher, it actually confers higher dosings or higher dosage of your ICS formoterol. And so on step 5, there is now an addition of a long-acting antimuscarinic agent. And then there's also this is also the time where we have to refer to a specialist, either a pulmonologist, an allergologist, okay? And also we have, at this point in time, we will take into consideration add-on regimens such as your anti-IgEs, anti-IL-5F5R, or the anti-IL-4 or alpha, or the anti-TSLP. In track 2, as mentioned earlier, we make use of 2 inhalers, 1 controller, and 1 reliever. Same as also as you go higher in this track 2, we also have an increase in the dosage of the inhaler. Again, step 5 is also the same as track 1, wherein we can actually take into consideration the use of your LAMA and refer to a specialist and somehow make use of other regimens, like I said, as was mentioned earlier, the anti-IgE, and so on and so forth. So this is very important because this is actually a breakthrough finding in research as to why not treat inhaled SABA alone. So when I say SABA, or short-acting beta-2 agonists, I mean salbutamol. In the Philippines, it's marketed as salbutamol. In the States, it's marketed as albuterol. So SABA treats the symptoms, but not the disease. We have to take into consideration what was mentioned earlier, wherein the cornerstone or the underlying pathophysiology of asthma is actually inflammation. So to counter or to address inflammation, the use of SABA cannot control or address the main problem of asthma. So it has been found that regular use of SABA
even for 1 to 2 weeks, is associated with increased airway hyperreactivity, reduced bronchodilator effect, increased allergic response, as well as increase in eosinophil. This can lead to a vicious cycle encouraging overuse, and it has been found that when you make use of SABA, uh, overuse of SABA, like you make use of at least of more than 3 inhalers of salbutamol in a year, it has been associated with an increase in exacerbation and increase in asthma-related deaths. So starting the treatment with SABA actually trains the patient to regard it as their primary asthma treatment. So we have to, as early as now, we have to recognize that uh, we have to start the patient in an regimen in a regimen that contains an inhaled corticosteroid. Okay, so specifically, it should be using an as-needed ICS formoterol, even for patients with um, intermittent asthma or partly controlled asthma. So in as-needed low-dose ICS formoterol in mild asthma, this was the study by Auburn in 2018. It's been shown that there is actually a improvement in the outcomes for severe exacerbations when the patient makes use of an as-needed budesonide formoterol to as a controller reliever compared to when they make use of a SABA. Here in the study, they made use of terbutaline. So in this study by Crossingham et al. In 2021, there is a significant improvement, or there is a preference of using the ICS formoterol to minimize emergency visits and hospitalizations in patients with mild asthma. So this is only an as-needed ICS formoterol. So they don't make use as regularly. For mild asthma naman. Okay? So GeneTrack 1, especially in steps 3 to 5, we have what we call as MART. It is the maintenance reliever therapy by using one inhaler. So MART with ICS formoterol has been shown to reduce the risk of severe exacerbations requiring oral corticosteroids. So there is a significant number of reductions, or with compared to the same dose of ICS LABA, as to the reduction in exacerbations, as well as using the ICS LABA, higher dose of ICS LABA, as well as making use of SABA. So it doesn't actually have a anti-inflammatory effect because formoterol as a reliever reduces risk of severe exacerbations compared to SABA reliever, considering that formoterol is a long-acting beta agonist compared to your salbutamol. MART has been also found to be more effective than ICS LABA plus SABA reliever in both eosinophilic and non-eosinophilic asthma. So MART has been being used in approximately 120 countries as of the present. So again, as I mentioned here, so it's just an illustration that you make use of your budesonide formoterol as a DPI or dry powder inhaler, or as a pressurized meter dose inhaler. So steps 1 and 2 is when you make use of the ICS formoterol as needed, or whenever there are symptoms of asthma exacerbation. And in step 3, we make use of a low dose inhaler, lower dose. So we make use of the same inhaler of your budesonide formoterol, and then you take it one inhalation once or twice daily, and one as needed. So there's an as needed dose in between, the maintenance dose of one inhalation 1 to 2 times a day, morning and evening. In step 4, there's now a medium dose. So you make use of the same inhaler of budesonide formoterol, and we use it for two, and we ask the patient to use 2 inhalations 2 times a day, which is the maintenance doses, which are the maintenance doses, and we also can using the ICS formoterol, the budesonide formoterol, we can advise the patient to use 1 inhalation anytime as needed in between the maintenance doses. So for example, if the maintenance dose was scheduled every 6 a.m. and 6 p.m. and somehow the patient wakes up around 10 p.m. after an hour's sleep with bouts of coughing, shortness of breathing, chest tightness, and even audible wheezing, then we can actually tell the patient that she or she can use or have another inhalation of budesonide for months. So budesonide formoterol can actually be given with a maximum total dose of formoterol in any one day with a formulation of up to 72 micrograms in adults and 48 micrograms for children 6 to 11 years of age. Remember, ICS formoterol is the only ICS LABA combination that can be used as an anti-inflammatory reliever. So you have to look into the GINA for the lists, complete lists of the different combinations of your ICS and your LABA. For patients who are 12 years and older, the maximum total dose of your budesonide formoterol in any one day is 12 inhalations. We have to remember that we can only make use of a budesonide formoterol preparation of 200 per 6 or 160 per 4.5 as the controller reliever, because in the market there's actually a 320 per 9 budesonide formoterol preparation in the form of your Symbicort. This preparation, the higher dose, is actually not recommended to be used as a controller and reliever combination as advocated by GINA. But if your patient will actually, you have to also remind your patient that if you go higher, if you take as much as 12 inhalations in a day of your budesonide formoterol, it's actually a sign that they actually need to have a consultation with their doctor or go to the emergency room ASAP. Or you also have to educate the patient that with a high dose of your budesonide formoterol, it comes with the side effects. So what are the common side effects of budesonide formoterol? This would include palpitations, tremors, okay, even dry mouth, and sometimes oral ulcers, as well as increasing cough because of the steroid content in the inhaler. In trap 2, so again, there are two different inhalers that you can take together as needed. And then on step 2, you make use of low dose inhaler, low dose maintenance ICS, wherein you make use of 2 inhalers, but you use the ICS containing inhaler more often than the as needed one, which is the SABA. And in step 3, this is now a daily maintenance of your inhaler at a low dose. So you make use of one inhaler as a controller, and then we also make use of another inhaler, or we make use of a nebulizer to give a dose of your reliever medications in the form of your salbutamol. Okay.